Good afternoon, everyone. I welcome you all for today's CCR by the Department of Rheumatology. And to start with itself, we have a question for everyone. What do you think is the work of Picasso? When I was asked this question the first, I also did not know, unless the speaker gave me the clue that Picasso's work is all about synthetic cubism. And then it was not difficult for me to find out that the top right corner is probably the picture which made by Picasso. And then once I learned this pattern, it was never difficult to identify more of his work just based on the information that was provided to me. Similarly, rheumatic diseases are mostly identified based on the joint involvement pattern. Like in patients with rheumatoid arthritis, lupus, and Sjogren, we have more of peripheral arthritis in the form of hand and foot joint involvement. Whereas in diseases which are spondyloarthritis like ankylosing spondylitis, psoriatic, and reactive, we have more of axial skeleton involvement at the form of spine, hips, and shoulders. Though we have serological and genetic markers for both the diseases, but they are not sacrosanct. And therefore, in making the diagnosis, clinical picture dominates over these markers. Recently, in the last 6 months, we saw 2 cases where this traditional knowledge was not enough to make the diagnosis, and we are presenting you those 2 intriguing cases today. I invite Dr. Sumit from our department to start the cases.
Good afternoon, everyone. So this is a 32-year-old lady with pain and swelling in joints since last 10 years, and hip pain and low back pain since last 3 years. Presented to us in the month of February. She was symptomatic since last 10 years. She has pain and swelling in multiple large and small joints of both upper and lower limb, and they had significant early morning stiffness. So to summarize, this is an inflammatory polyarthritis, and on further workup, we found that the patient has high titers of rheumatoid factor and anti-CCP antibodies. In her treatment history, she has taken disease-modifying drugs like methotrexate, sulfasalazine, low-dose steroids in variable doses, and even she has shifted to alternate system of medicine. For the duration of total 10 years, she has taken those medicines for 5 years. She did well in the first 7 years, and after that, she started developing progressive deformity in wrist joint. Since last 3 years, she has new joint involvement in form of hip joint and low backache. Now, in last 3 years, the pain and stiffness she used to feel in lower back in early morning, and it used to be significant more than 30 minutes. So this is something is inflammatory back pain, and there was a progressive functional limitation. She was unable to squat or sit with cross leg, unable to separate her legs, unable to bend forward. So there was no episodic nature of symptoms, which if there is an episodic nature of symptom, it suggests to be reactive arthritis. And there was no extra-articular features like uveitis, enthesitis, or dactylitis. Currently, she was on methotrexate 15 milligram per week, but with mild relief in her symptoms. Her past and menstrual history was not significant. Neither she had any history suggestive of psoriasis in herself or in any family member. So we, in our clinical history, made a differential of psoriatic arthritis and rheumatoid arthritis with hip involvement. On examination, we were able to find multiple solid and tender joints, and DIP was spared. So DIP is typically involved in psoriatic arthritis, and on further examination, there were restricted movements in her right wrist and bilateral hip joint. On general examination, pallor were present, and systemic examination, nothing significant was found. On further examination, modified Schober's stress was 4 cm, intermalleolar distance is 67 cm, lateral friction was 12 and 11 cm, and occiput to wall was 0 cm, cervical rotation was 70 degrees. I will want Dr. Lokesh from radiology to discuss these.
Thank you. Good afternoon. So in this skeletal radiograph of both the hands, we can see there is periarticular osteopenia. This is the periarticular osteopenia, and there is reduction in the intercarpal distance, and there is some amount of sclerosis at the end of the radius bilaterally. This is the zoomed image. This is the reduced intercarpal distance. As seen in the opposite side, it is normal. Here it is reduced. And on the pelvic X-ray, we can see there is bilateral symmetrical sclerosis of the hip joint, bilateral femoral head with reduced joint space diffusely. And also we can look at the SI joint, there is some sclerosis at the iliac side, more on the right than the left. And on the spine we can see there are end plate sclerosis, and there is some amount of degenerative change in form of some osteophytes are also coming in this, and there is diffuse osteopenic. So to summarize, there is reduced intercarpal distance, and our differential in this case would more towards the rheumatoid arthritis. In psoriatic arthritis, we don't see an osteopenic bone, and also this can be an overlap with AS based on the spine and the pelvic X-ray.
So what we had was a peripheral arthritis, there was a hip involvement, there was sacroiliitis, there was osteomatous spondylitis. The seropositivity here was rheumatoid factor positivity and anti-CCP, and HLA-B27 by PCR method was positive. So when we try to fit our patient in this classification criteria of ACR-ULAR 2010 for rheumatoid arthritis, we can see our patient has 4 to 10 small joints, and there was high titer positivity of rheumatoid factor and anti-CCP, and there was there was raised ESR and CRP, and the duration of patient symptoms were more than 6 weeks. When we look for the SRS classification for axial SPA, we were able to find that there was sacroiliitis on X-ray, there was an inflammatory back pain, there was a peripheral arthritis, and HLA-B27 was positive. So with all this above classification, we made a diagnosis of overlap of rheumatoid arthritis with ankylosing spondylitis. Presently, this patient is being shifted on sulfasalazine and doing well. This is another case where we had this 26-year-old female present with pain and swelling of multiple joints since last 6 years and low back pain since last 3 months. She visited us in the month of August. Since last 6 years, pain and swelling of multiple small joints were there. Patient had significant early morning stiffness, again an inflammatory polyarthritis, and again the sero markers were rheumatoid factor and anti-CCP were strongly positive. The patient started developing progressive deformity of small joints of both hands and feet, and in last 3 months, patient had significant inflammatory low back pain. Now there was no history suggestive of any psoriasis, uveitis, enthesitis, dactylitis, or any inflammatory bowel disease, and there was no episodic nature of this disease. Nothing much significant was found in her past and personal history, and there was no family history of any spondyloarthritis or psoriasis. Now we had a differential of psoriatic arthritis and rheumatoid arthritis with hip involvement. On examination, we found multiple solid and tender joints, and right wrist there was a severely restricted movement in range of severely restricted movement, and there were deformities of toes, as you can see.
Start with the skeletal video of the hand of this patient. As you can see, there is evident there is scalloping at the ulnar side of the distal end of radius, and there is osteopenia in the periarticular region, and there is joint degenerative change as well with reduced intercarpal space. And on this you can see there is in the proximal interphalangeal joint there is marginal joint erosions, osteopenia at the periarticular region, involving this is the third, fourth, and fifth digits both are involved, and also at the metacarpal head you can see there is peripheral illusions and central penicillin cup deformity. On the other hand, also similar changes were noted with there is also joint subluxation in the second interphalangeal joint, and there is also reduced joint space. So in the foot also we can see this metatarsal head also shows marginal joint erosions and osteopenic bones. Also, on the lateral we can see there is some flexion deformity of the toes as well. In the pelvic radiograph we can see there is the bilateral SI joint shows sclerosis and some bony ankylosis. Also at the superolateral margin of this left hip, we can see there is some joint space reduction with some mild sclerosis. So there was periarticular erosions, and MR was also done. In this case, we can see bilateral stir hyperintensities in the lower SI joints, and this is the stir image which shows hyperintensity in bilateral hips. Also, this is the post-contrast image which shows some periarticular erosions, and there is also post-contrast sensitive of active disease.
So again, in this case, we had a peripheral arthritis, a hip involvement, a sacroiliitis, seropositive in form of rheumatoid factor positivity and anti-CCP high titer. And HLA-P27 in this case was negative by PCR. So Again, if you try to classify this patient, again, I had 4 to 10 small joints. There was a high titer rheumatoid factor anti-CCP. There was raised ESR and CRP, and the duration was more than 6 months. But in this case, we had an MRI imaging that was suggestive of sacroiliitis with inflammatory back pain, arthritis, and there was a good response to NSIDs, and there was elevated CRP. So our diagnosis in this case was overlap of seropositive deforming RA with spondyloarthritis, and patient is being started on methotrexate plus tofacitinib. A review of literature will be done by my colleague Dr. Nadeem.
Good afternoon, everyone. So before discussing the review, we will just compare between the rheumatoid arthritis and spondyloarthritis. Rheumatoid arthritis clinically presents with typically a symmetrical small joint involvement and usually involves the appendicular skeleton. Involvement of axial skeleton in the form of spine is very rare, except for the cervical spine, which is around 80% involvement in RA. Spondyloarthritis usually affects the axial spine, preferably as sacroiliitis, presenting clinically as low backache. And the prevalence rheumatoid arthritis is more common than spondyloarthritis, and RA has a prediction to females. So regarding the diagnosis, X-ray radiological features help in diagnosis. RA has erosive features, while these spondyloarthritis spectrum of disorders have newborn formations, syndesmophytes, and usually non-erosive. So regarding the diagnosis of RA and spondyloarthritis, we have a rheumatoid factor and anti-CCP for diagnosing rheumatoid arthritis, but there is no such serological markers for spondyloarthritis. So we use HLA-B27 genetic marker as diagnosis of spondyloarthritis. It forms one of the criteria of the diagnosis. However, the genetic marker for HLA-DR4 for rheumatoid arthritis we don't traditionally use because we have other criteria. So just the treatment of spondyloarthritis is important because the treatment varies depending upon whether there is an axial spondyloarthritis or it's a peripheral spondyloarthritis. For axial spondyloarthritis, the typical involvement is sacroiliac joint and the lumbar spine, whereas in the peripheral spondyloarthritis, it's mostly the peripheral joints of appendicular skeleton, mainly the knee joints and the elbow and the shoulder. So some of the drugs only work in peripheral, for example, sulfasalazine, while the anti-TNF alpha inhibitor is indicated for axial spondyloarthritis. The most common form of spondyloarthritis is axial SPA, and the most commonest disease is ankylosing spondylitis, which represents 45% of all SPA spectrum disorders. The criteria used are used for classification and is not used for diagnosis. So this is a pictorial representation of joint involvement in different arthritis. So the left represents typically symmetrical joint involvement. Small joint is more involved. Appendicular skeleton is more involved than the axial skeleton. This is typical of rheumatoid arthritis. The right corner, the right extreme image represents the axial SPA, where the joints involved are predominantly central joints, which is the SI joints and the lumbosacral spine. If at all, if it involves the peripheral joints, it usually involves the knee in an asymmetric fashion. It's an oligoarthritic fashion. The middle image represents a peripheral SPA, where the axial skeleton is also involved along with the peripheral skeleton, but it is not symmetrical. So the middle example is a typical example of psoriatic arthritis, and the last is an axial SPA. So while discussing the overlap of RA and AS, the incidence of RA with AS is very rare. It is around 1 in 50,000 to 1 in 2 lakhs. So the first case of RA with AS was first described by Wilkinson when he tried to summarize 222 hospital referred cases of ankylosing spondylitis. One of the patients had typical symmetrical small joint involvement, typical of rheumatoid arthritis, which occurred 25 years after the onset of ankylosing spondylitis. So this case he mentioned separately as the first case of AS with RA overlap. So we'll just briefly discuss two studies about the overlap of SPA with RA. We'll be discussing two cross-sectional studies, one in Turkey and one in Egypt. So they took 167 patients with rheumatoid arthritis satisfying the ACR 1987 criteria, and they took other three criteria for assessing the SPA features in these patients. So one of the criteria for Kalin and experts for inflammatory backache and axial SPA AS criteria. The AS criteria was already described by Dr. Sumit. So what is an inflammatory backache? Usually occurs 3 days in onset, greater than 3 months of duration, worse at night, worse in morning, improving with exercise or any physical activity. So the demographic goes as such. There was a female percentage of female patients in the case series was high. Nearly 80% of patients who had RA were female, and the mean age of diagnosis was 46. So among this 167 patient, nearly 17% in the Calix, they had satisfied the criteria for inflammatory backache, which is typical of SPA. So the next most common feature of spondyloarthritis in these RA group are enthesitis. So they did follow a specific algorithm for looking for the features of spondyloarthritis, including a pelvic X-ray. If it was not clear, they did an MRI to look for SO-sacral leg joint involvement. So the results were, among the 167 patients, nearly 2% had ankylosing spondylitis in the RA group, and the axial SPA was 5.3 in the RA group. So this is not as rare as we thought. So this is the next study done in Egypt. They took 100 consecutive patients with RA satisfying the ACR 2010 criteria. The study was done after 2010. The criteria used for assessing SPA was similar to the previous studies. So again here there was a female preponderance of the female sex ratio was high. It was nearly 80% and the male were 20%. The age of onset of RA was a bit earlier than the previous case series. So again in this patient, it was surprising that the percentage of AS diagnosed classified using the criteria was very high, 20%, and the patients satisfying the axial SPA criteria was 27 in those RA patients, and 22 had radiographic sacroiliitis despite having an RA. So why there was a huge difference, 2% in the first study and nearly 20% in the second study? This can be explained by the prevalence of HLA. The HLA HLA prevalence in rheumatoid arthritis is similar to that of a general population, meaning that HLA doesn't influence the RA. However, in this case series, the case series presented second, the prevalence of HLA is 35%, which is nearly 6 to 7 times higher when compared with the general population or a normal or a cohort of RA population. So higher the prevalence of rheumatoid HLA-B27 in RA patients, they tend to exhibit sacroiliitis, usually grade 3 or 4. And if at all they didn't satisfy any of the criteria for SPA, still they had HLA-B27 positive, then the sacroiliitis were either grade 1 or 2, but they were not satisfying the other SPA criteria. So meaning that the HLA-B27 is positive, higher the chance that the rheumatoid arthritis patients may evolve or develop a spondyloarthritis feature later, especially sacroiliitis. So this is one of the summary. There is a 81 case series, a case series of overlap cases of RA with AS, 81 patients from 1950 to 2022. So the first disease diagnosed in the cohort was rheumatoid arthritis. It was 52% of patients had rheumatoid arthritis first, and 14% had ankylosing spondylitis initial presentation. And here the male ratio was a bit higher, contrasting to the previous two studies. So male represented 71%, and the HLA-B27 was even more higher. It was 90%. So while the HLA-B27 was very high in this case series, it's because they had taken only the patients who had diagnosed SPA. So one patient to pick a SPA on a background of RA, the patient should have a fully manifested SPA. So that's the chances the HLA-B27 positivity was high. So the treatment, we just discussed about the treatment. And most of the patients, 99 patients, had sacroiliitis in the both groups. So regarding the treatment of RA and SPA, there is some difference. The rheumatoid arthritis, the conventional DMRD do play a role, while if the patient is not responding, we do switch for anti-TNF therapies or biologicals, including rituximab. But however, in the axial SPA, the conventional DMRDs like sulfasalazine, leflunomide and HCQ do not have any role. And the first drug is NSAID. If the patient is not responding, straight away we go for anti-TNF therapy or JAK-STAT inhibitor. So in case if the patient has RA and SPA, I think the drug which can work for both groups is the TNF alpha inhibitor infliximab and JAK-STAT inhibitor tofacitinib. Thank you. I will invite Dr. Ranjan sir for further feedback.
Thank you, Dr. Naveen. So if we look at the spectrum of this inflammatory arthritis and we go from a classical peripheral arthritis of rheumatoid to the classical axial presentation of ankylosing spondylitis, we have a whole spectrum of diseases. Like patients who have rheumatoid arthritis, they can be seronegative, as is shown in the second picture. Then we have got psoriatic arthritis, which has got some features of peripheral and axial disease. Then we come to reactive, where peripheral becomes lesser. They have got axial and peripheral joints in the form of large joints. And then we come to axial, pure axial ankylosing spondylitis, where we have got only axial joint involved. And as we go across this spectrum, we see that there is symmetricity, peripheral arthritis, and upper limb involvement on the left hand side. Whereas as we go towards the right hand side, we have got asymmetricity, axial skeleton involvement, large joint, core joints of hip and shoulder. Similarly, if we look at the seropositivity, which is more on the left side, and B27 positivity is almost negative, whereas we come to the right side, B27 positivity increases to almost 85%. And among treatment also, this disease biology affects, because if we look at rheumatoid arthritis, rituximab is one of the treatments, whereas rituximab doesn't work at all when we come to the right hand side of the spectrum. Similarly, IL-17 therapies and anti-TNFs are more useful in patients who are on the right hand side of the spectrum in axial SPA as compared to people who have rheumatoid arthritis. So basically, these are two different diseases, rheumatoid arthritis and ankylosing spondylitis in the spectrum, and finding them both together is a rarity, as has been shown in the last slide by Dr. Naveen, that there are only 81 reported cases, and we have seen 2 cases in the last 6 months. So probably we have also started diagnosing it more and more now as we have come across and we have got to know about this entity. And with this, I would like to acknowledge both the patients, their cooperation, and the Department of Radiodiagnosis in making this CCR possible. I thank the audience for their patient hearing. I would be happy to take the questions if there are any. Thank you. Yeah, please.
So my concern was, what was your intention for using JAK inhibitor patient? Wondering why TNF?
Yeah. So TNF inhibitors, number one, they are costly, almost 10 to 15 times costlier as compared to the JAK-STAT inhibitors. Moreover, the recent studies have shown that among the newer molecules, JAK-STAT inhibitors are the only medicine that can be used in rheumatoid arthritis as well as ankylosing spondylitis, and they have good efficacy in SPA also. So that is the reason why we have thought of using tofacitinib in these patients. Otherwise, sulfasalazine has been conventionally used and it also works. I think the cases are so good that so if there are no questions, we thank the audience. Thank you.
A very good afternoon. Obesity is now a global pandemic. I think more and more men, women needing to take in for bariatric surgery with morbid obesity. Now, these problems and challenges are very many, and I know Dr. Sandeep is here. But the challenges grow much more when there is a young woman in the childbearing age wanting to become pregnant, and the pressures are far more than just losing weight. So here we have an interesting case who, in the process of planning a pregnancy, realizes that she was pregnant while she was undergoing a bariatric surgery. So to present this interesting case, we have Dr. Ria, a junior resident, followed by Dr. Soni, who is going to share the review of literature, and Dr. Vidushi will give the comments as she was actually involved in managing the patient. So over to you, Ria. Yeah. Yes.
Good afternoon, everyone. Good afternoon, everyone. Today I will be presenting a topic, bariatric surgery in pregnancy, tipping the scale. It's not okay. Mrs. X, 33-year-old female with class 3 obesity with a BMI of 50.3 kg per meter square, presented at AIIMS at 6 weeks of gestation. She had undergone bariatric surgery at Indore 2 weeks earlier at 31 days from her last menstrual period. UPT was done 2 days prior to the surgery, which was negative. She consulted her parent bariatric unit in Indore and she was advised termination of pregnancy. She sought consultations at multiple obstetric and bariatric units in Indore, Mumbai, and Delhi, and there she was advised the same. She was married for 4.5 years and was keen to conceive since 1.5 years. She was trying actively for pregnancy over the last 7 months. The couple was investigated. The husband's semen analysis was normal and the tubal tests were not done. She was advised weight loss and was put on a strict calorie diet of 1600, which provided little benefit. She was given ovulation induction with letrozole. She was given 4 cycles along with timed intercourse. She did not get pregnant at that time. Assessment of ovarian reserve was done, which showed AMH of 0.9 and AFC of 8. Reduced ovarian reserve with morbid obesity gave the option of artificial reproductive technology. Considering the less benefit and dietary modifications, she was advised bariatric surgery for weight loss prior to IVF cycles. Patient opted for bariatric surgery in November 2022. Her previous cycles were regular and were of length 26 to 27 days. There was no obesity-related complication in the patient. Her last menstrual period was on 7th October and patient was planned for bariatric surgery on 7th November. She continued her unstructured diet restrictions and took semi-solid diet 5 days prior to the surgery. UPT was done 2 days prior to the surgery, which was negative. Post-surgery, patient did not get her periods, and as her cycles were regular, she repeated her UPT, which turned out to be positive. The scan for pregnancy confirmation was done at 5 weeks of gestation, which showed intrauterine GSAM. Now comes the dilemma. There was infertility of 1.5 years, BMI of 50.3. There was diminished ovarian reserve already. and there was chances that patient might not get pregnant again, even with the weight loss. And yet the weight in this pregnancy has not been optimized, and there might be complications associated with it. There is also risk of NTD and FGR in the baby. Only 3 case reports are available till now. After seeking all the points, the decision for continuation of pregnancy was taken, and the patient was counseled that the benefits of bariatric surgery will be undone, and her pregnancy will be high risk as she will have acute weight loss, and the risk of morbid obesity related complications will also be present in the patient. Literature was reviewed and couple was counseled thoroughly regarding the potential risk. Shared decision making was done and patient was booked at AIIMS. At booking, she was 7 weeks gestation. She had already lost 10 kgs after 3 weeks of bariatric surgery. Now, we already had concerns of calorie and micronutrient deprivation. A multidisciplinary approach was taken and expert opinions were taken from bariatric surgery department, physiotherapist and nutritionist. In the first trimester, for starting 30 days, patient's diet was divided into phase 1 and phase 2. Phase 1 consisted for 15 days, which had liquid diet and calorie of 400 and protein 18 grams. Phase 2 was for 15 days for puree and mash diet, calorie 600 and protein 18 grams. Folic acid along with fat-soluble vitamins, iron, calcium, zinc, vitamin C were given. Vitamin B12 injections were given weekly for the starting first month. Patient was started on oral ecosprin. First trimester adequacy screening was negative. Quickening was perceived at 20 weeks of gestation and patient continued her phase 3 diet and micronutrients. Blood sugar profile instead of OGTT was done, which was within normal limits. Patient had normal blood pressure records throughout the pregnancy. Now starts the roller coaster ride, which started in second trimester. At 16 weeks of gestation, she had complaint of lower abdominal pain and on ultrasound, 2 cm cervical length and funneling was present. Emergency McDonald's circulage was placed and patient was discharged on dydrogesterone and enoxaparin. At 19 weeks, she was again admitted and was managed conservatively with the complaint of pain in lower abdomen. Serial cervical length monitoring was done. Dydrogesterone was discontinued in view of deranged LFTs. Fetal anomaly scan at 20 weeks showed isolated hypoplastic nasal bone, for which non-invasive prenatal testing was done, which was low risk. Patient had off and on rectal lower abdominal pain in third trimester, for which cervical length measurement was done. Her cervical length was from 1.8 to 2 cm, but the stitch was intact. Patient was admitted at 29 weeks for threatened preterm labor. For fetal lung maturity, dexamethasone coverage was given. During that time, blood sugar monitoring was done. At 33 weeks, she was admitted with complaint of spotting per vagina. Enoxaparin was discontinued and it was restarted after 2 days. She had complaint of itching over the whole body, for which LFTs and bile acids were done, which was within normal limit, and it was relieved on topical lactocolumine. Patient was planned for vaginal delivery. She was admitted at 37 weeks for safe confinement. Cerclage was removed and she was induced with dinoprogesterone gel at 38+4. There was marginal response with second gel and patient was augmented with oxytocin. As the fetal heart rate could not be monitored, intrapartum continuous CTG was done. Epidural analgesia was given for pain relief. She underwent successful vaginal delivery. She had a baby of 3.2 kgs with Apgar 9/9. No PPH. She did not have any PPH and the postnatal period was uneventful. She was discharged on postpartum day 3. Now this chart represents what were the nutritional intakes and supplementations patient did throughout the pregnancy. It was structured according to the patient by dietitians. She had strict kilocalorie and energy intake and protein intake and by supplements throughout the pregnancy. This graph shows the weight during the course of pregnancy. At the time of admission, at the time the patient presented to us, her BMI was 50.3 and at the time of delivery, her BMI was 49.6. Now the patient is still in her weight loss journey. Her BMI after 3 months is 46.5. Thank you. Dr. Soni will continue. Good afternoon. Coming to discussion and review of literature part, obesity. Obesity is growing worldwide and has been described as global epidemic by WHO since the prevalence of overweight and obese have tripled in the last few years. So owing to more increase in the prevalence of obesity, the bariatric surgeries have also increased and pregnancy following bariatric surgeries will more commonly be encountered by us. So various societies gave recommendations for pregnancy following bariatric surgery in 2019, which says conception should be avoided for at least 12 to 18 months post-bariatric surgery to avoid obesity-related complications and to reduce the adverse effect of nutritional deficiencies, which will be during the rapid weight loss phase. There are three types of bariatric surgeries: restrictive, malabsorptive, and mixed procedures. Restrictive has adjustable gastric banding and sleeve gastrectomy, in which small gastric pouch is created, keeping the continuous intestinal continuity is kept intact so that digestion is normal and absorption of nutrients is also intact. So micronutrient deficiencies can only occur because of restrictive food intake or low nutrition dense food choices. In malabsorptive procedures, duodenum and jejunum is bypassed, leading to malabsorption, and in mixed procedures, we have Roux and Y gastric bypass, in which we create a straight limb connected to gastric pouch, and the Y portion is downstream as enterostomy. This leads to both reduced food intake and limited absorption. And in sleeve gastrectomy, 80% of stomach is removed, which restricts the holding volume and reduces the amount of food consumed. In pre-bariatric surgery preparations, patient is selected on NIH consensus criteria. The type of surgery is decided on the basis of patient's comorbidities and surgeon's experience. It mainly consists of preoperative weight management program, which includes weight loss by diet and physical activity. This will reduce the post-op complications, it will shorten surgery time and improve the glycemic status of the patient, and also includes the micronutrient supplementation to prevent pre-op nutritional deficiencies, post-op nutritional deficiencies, and metabolic complications. Contraception during this period is strongly recommended as conception may occur. We have three scenarios for pregnancy after bariatric surgery. First is conception after in the recommended time, that is 12 to 18 months after surgery, for which we have abundant literature. Conception within 12 months of surgery, in which we have limited literature, but for the cases who got already pregnant at the time of surgery, only 3 published case reports are present in date. Coming to impact of surgery on reproductive outcome, surgical weight loss improves anovulation, irregular menses, PCO and thus improves fertility, which has been well documented by various literatures, in which one study documented 42% infertile women became pregnant just post-surgery, 22% PCOS patients became pregnant post-surgery, and 37% chance of pregnancy increased after surgery in the patients who had prior history of unsuccessful ART. So we have 3 published case reports for bariatric surgery in pregnancy. Out of these 3 cases, two ladies underwent laparoscopic sleeve gastrectomy, were diagnosed pregnant 4 weeks after surgery, and once they were found pregnant, they were monitored by the multidisciplinary approach of a team of obstetrician, nutritionists, physiotherapists. The course of pregnancy went well, and they delivered at term, and also they delivered at term with the appropriate for gestation age baby. While one case report says that a obese patient underwent Roux and Y gastric bypass, she was diagnosed pregnant after 8 weeks of surgery, but she started experiencing severe abdominal symptoms 4 weeks after surgery, for which she was evaluated. And upper GI endoscopy showed narrowed anastomosis with ulcer, for which balloon dilatation was done. The symptoms persisted despite strict antiemetic protocol and could not be relieved, and this patient had to undergo termination of pregnancy. Fourth is our case, for which we have discussed all the roller coaster ride that she went through in her pregnancy. So the case that we discussed, she had 8.5% body weight loss at 10 months after surgery.
This is a case of pregnancy conceived after 3 months of surgery. This lady underwent Roux-en-Y gastric bypass surgery. So with 75 grams glucose load challenge test, she experienced GI symptoms and was diagnosed with dumping syndrome. So she had persistent GI symptoms leading to malabsorption, nutritional deficiencies for which she developed fetal growth restriction at 30 weeks with brain sparing, and the pregnancy has to be terminated at 34 weeks of gestation. Dumping syndrome is rapid movement of fibrous molar food from stomach into duodenum. They are basically early and late dumping syndrome. Early occurs within 1 hour after meals, in which patient experiences vasomotor and GI symptoms. Late dumping syndrome occurs 1 to 3 hours after high carbohydrate meal. So the incidence of this dumping syndrome is very high, 40 to 76% after Roux-en-Y procedures. While in sleeve gastrectomy, early dumping syndrome is seen up to 30%. Whereas these two societies have given recommendations for pregnancy after bariatric surgery in the periconception, antenatal, and the postnatal care, which is summarized here. The time from surgery to conception is postponed till stable weight is achieved. Contraception contraception has been focused, and LARC is encouraged, long-acting reversible contraception. This recommendation focuses on nutritional advice that the food with low glycemic index and smaller meals should be taken. Nutritional supplement in form of folic acid, calcium, citrate salts, iron, and all other micronutrient supplementation should be done. The nutritional monitoring should be done every trimester and 6 monthly. For diabetes screening before pregnancy, we can do with HbA1c, while for doing OGTT at 24 to 28 weeks, instead of 75 gram, we can use 50 gram glucose load, or we can alternatively go to fasting and postprandial blood sugar 10 for 1 week. Gestation weight gain recommendation is 5 to 9 kg increase, that is 0.23 kg per week in second and third trimester. Coming to ultrasound scans, first trimester NT&B and biochemical screening is important. Second trimester detailed anomaly scan. And the fetal growth surveillance starting from 28 weeks every 4 weekly should be done. Mode of delivery vaginal and cesarean done only for obstetric indications. So, pregnancy outcome after pediatric surgery. This is a meta-analysis which includes 20 cohort studies and 2.8 million pregnant women, out of which 8,364 pregnancies are post-bariatric surgery when compared with obese pregnant patients without bariatric surgeries. And the obstetric outcome was evaluated. The antenatal complications such as gestational diabetes, gestational hypertension, preeclampsia, large gestation macrosomia, cesarean delivery, and PPH are less seen in pregnancies after bariatric surgeries, while the complications like preterm delivery, IUG, small for gestation, malformations, neonatal death, and neonatal were more. So the conclusion is that post-bariatric surgery pregnancies have potential for several important adverse obstetric outcomes which should be addressed. This meta-analysis further reported that there is increased incidence of FGR and SGA fetuses in malabsorptive surgeries compared to restrictive surgeries. The same result was also documented by another study that's quoted here. This study quotes that the antenatal and postpartum complications like GDM, gestation, hypertension, preeclampsia, PPH, or difficult deliveries, instrumental deliveries are more common in obese gravida, but once the pregnancy is after bariatric surgery, these complications are decreased. Contraception is given very much most importance before surgery because before optimization, the pregnancy should not be done, and so starting contraception prior to surgery and strictly adhering to it is very important. Coming to contraceptive choices, we know LARC is very well favored, but combined hormonal contraceptive pills can be given in patients with restrictive bariatric surgeries. So the take-home message is pre-bariatric surgery contraception is very important. Conception immediately after bariatric surgery is challenging for patient, obstetrician, and family as well. Management is by multidisciplinary approach with a team of obstetricians, nutritionists, and bariatric surgeons. as sleeve gastrectomy is associated with less fetal maternal adverse outcomes and can be preferred choice of surgery. Now I invite Dr. Anju, consultant anesthesia, to provide her inputs.
A very good afternoon, everyone. I am grateful to Neerja ma'am and entire Gynae department for this opportunity to present my brief perspective. So my colleagues from Gynae department, they have presented their enormous challenges which they faced, but even our anesthetic challenges are no less. I would be briefly discussing some of them. So we have this super morbidly obese patient here who presented to us in term pregnancy for this labor epidural. But at any time we were prepared to take her up for cesarean section also. This kind of super morbidly obese patient, as you all would agree that from beginning from head to toe, we have this entire gamut of organ systems which are involved related to super morbidly obesity itself. And on top of that, we have a term pregnancy. So all of the complications are compounded by many times. So beginning from head to toe, a lot of organs are involved, which lead to many pre-operative considerations for us. Beginning from airway, there is increased risk of difficult intubation in this parturient, then increased risk of obstructive sleep apnea, then cardiovascular, lot of risk of there, cardiovascular hypertension, ischemic heart disease, cardiomyopathy. All these have their implications, and we are prepared to go for advanced tests at a lower threshold. Then GIT, there is an increased risk of aspiration, and we have to be prepared for that. And in addition, we have some metabolic changes like diabetes mellitus and all. So all the anesthetic challenges here which we were facing were airway. There was a potentially difficult airway. So we had to be prepared for difficult ventilation as well as difficult laryngoscopy by making a ramp position and other preparations. The patient was prone for hypoxia because there is a severe impairment of the functional residual capacity. So we have to pre-oxygenate the patient well and provide PEEP, and also we have to be prepared for a difficult extubation. GI system, we have to provide an aspiration prophylaxis, and we have to we can go for a volume assessment pre-operatively using ultrasound. Also, these patients stand at twice the risk of deep venous thrombosis, and there is a increased risk of ischemic stroke as well as the hemorrhagic stroke, which each unit increase in the BMI. The cardiovascular and respiratory system are already compromised. These patients have increased incidence of gestational diabetes mellitus, and long-standing diabetes mellitus can lead to increased incidence of autonomic as well as peripheral neuropathy, which have an implication for regional anesthesia, which we were planning. Then pharmacokinetics, all the drugs, the metabolism is affected, and we have to go for titrated doses. Then we have to be prepared with the equipment specific for the bariatric patient. We have to be ready for the position, the high weight capacity beds, mechanical transfer systems, more extra personnel, extra long needles, and appropriate BP curves. So all these preparation have to be done in advance. So also in this patient, this patient was a post-bariatric surgery patient. So there were additional considerations regarding the nutritional deficiency, anemia, low protein, vitamin deficiencies, and regional anesthesia. In such a patient, we should be worried of any prevalence of vitamin K deficiency, which can lead to deranged coagulation status. Also, these patients may have anxiety disorders and other mental disorders and substance abuse problems like smoking. So we have to be prepared for that. And increased incidence of PPH, IUGR, which has been elaborated already. However, in such a patient, the anesthetic management more or less for us will stay as similar for a morbidly obese patient. So in this index case, we were prepared for a patient, we were facing a patient who had difficult airway based on our pre-operative assessment. This patient was a candidate for difficult airway. Then also there was a difficult regional, there was no, we could not palpate the spine at all. And also there was a lack of time because she presented in advanced first stage to prepare for the ultrasound scan of the spine. Or if there was also a high chance of failure of the regional, in which case we will have to go for parenteral and inhalationals like nitrous oxide, but that will stand the patient, the patient will face a risk of loss of airway reflexes, and potential difficulty airway in such a scenario will be a disaster. Also, there is an additional risk of accidental dural puncture, which is much higher in obese patients. And there was a lack of time for preoperative evaluation and optimization in such a patient. And class 3 obesity itself is associated with increased postoperative mortality and morbidity according to our literature. And this was a super morbidly obese pregnant patient. So obviously all the risks were much more. This was a late stage of labor. So lack of patient cooperation in positioning was additional challenge with us. And it was also on top of that, it was a precious pregnancy, and post bariatric surgery additional concerns were also there. Now coming to labor epidural, this is a labor epidural kit. How can I point? Is it working? Okay, so this is a combined spinal epidural kit. Here we have a combined spinal epidural needle through needle technique. So this is an epidural needle. We locate the epidural space with this needle, and then we puncture the spinal space, subarachnoid space here. This is a 2E needle. We locate the epidural space, and using needle through the needle technique, we puncture the CSF, the arachnoid membrane, and we go into the CSF and inject the intraspinal drug, and then we withdraw the spinal needle and we thread in the catheter for further management of the labor pain. So this is the combined spinal epidural. In the lumbar third, fourth space, on first attempt, on second redirection, I could locate the space, and after injection of 25 microgram of fentanyl with half a ml of bupivacaine 0.5%, there was an instant onset of pain relief. Patient felt very comfortable, and only a 5 ml top up was required, 0.1% top up with 2 microgram per ml fentanyl, and the patient delivered within 3 hours. So there was no delay related to the epidural, and we routinely monitor the patient satisfaction and record it. So this patient recorded patient satisfaction score of 9/10, which I believe is very good. Now, this patient, regarding the regional anesthesia, the main challenge was locating the midline and the insertion point. So these are the ways by which we can just monitor. So in this case, I could found the insertion point by dropping a line from occiput or C1 spinous process to the gluteal cleft, and a horizontal line at the level of iliac crest. At that point, I went in and I could locate. And also, obviously, there is ultrasound is coming up in a big way with the anesthetist also, and that will help in such cases. Now, benefits of Neuraxial in such cases, this is the most important thing to know, is that it provides excellent pain relief. In addition to that, it is the best modality of pain relief for labor analgesia. Additionally, it also reduces the oxygen consumption, and it provides improved maternal oxygenation, decreases the bulk of breathing, decreases plasma catecholamines, which also decreases dysfunctional labor and also decreases the cardiac work. These patients have an increased risk of cesarean section and potentially difficult airway. So presence of an epidural catheter allows us to provide surgical anesthesia whenever it is needed and avoid the airway manipulation whenever it is needed. So in fact, it is suggested that we can have a prophylactic catheter in C2, which will give us an additional margin of safety. Thank you very much.
Thank you, Dr. Anju. When this patient came to us in the first trimester, and when this shared decision was taken that she will continue the pregnancy, then we had close discussions with Dr. Sandeep Agarwal, and from time to time we sought his advice about how to go about throughout this pregnancy. So I would like to invite Dr. Sandeep to give his inputs regarding such cases.
A very good afternoon, and first of all, congratulations to the entire team for the successful management of this very challenging case. So when Dr. Neena first called me, I couldn't actually believe it, that a patient who was trying to get bariatric surgery and then subsequent pregnancy had a pregnancy detected immediately after bariatric surgery. Is almost unbelievable. And so the first thought was obviously a termination of pregnancy. But when the family met me, and obviously when you learn that the primary objective of the surgery was to conceive, and if she's conceived, there was no question of advising termination then. Of course, the main challenge is how will she eat? How will she maintain her own weight? Because on one hand, she's losing weight and she's expected to gain roughly 5 to 9 kgs of weight in the entire 9 months of pregnancy. And besides, obviously, the nutritional challenges and the vitamin and other deficiencies. So, but then she had a sleeve gastrectomy, which is not a malabsorptive procedure. So, we know that in first 3 months, yes, the calorie goals are intake is roughly about 800 calories. But then subsequently it increases. The patient can definitely increase the diet, maybe eat some high calorie foods and all. And obviously the protein consumption also has to be adequate. But after 3 months of the surgery, one can definitely increase the diet. So I think the challenging part that she should be able to take the nutrition was, I think, more or less, clear in our mind that she should be able to take that sort of nutrition required for sustenance of pregnancy and for the fetus. When the other challenge is obviously, the chance of the malformations due to surgical anesthesia, and as well as the increased chance of fetal complications even otherwise. Doctor, she showed data of increased neonatal mortality and small for gestational age babies. Even if the patient had conceived after 18 or months or 2 years of surgery, even then they have a slightly increased chance of fetal complications. So all this combined obviously made it a very high risk pregnancy, and I think it was very well managed, and I think it really resulted in a good outcome. The other two aspects I'll just like to say that patients who are morbidly obese, and we have an increasing number of patients now, but 1/3 of urban women are either overweight or obese. So, and they have a concomitant PCOD. I think bariatric surgery is an extremely effective means of having a successful outcome, not only in terms of weight loss, but also in pregnancy. They showed a roughly rate of 38 to 40% patients who are infertile become pregnant after bariatric surgery. So that's a very important, I think, lesson to take apart from what the case shows. The other aspect is about the timing of surgery, as has been pointed out. It's clearly the surgery should be timed after the weight loss is plateaued. The earlier recommendation was 12 to 18 months. Now it's that once the weight loss is plateaued, one can plan a pregnancy. And the last aspect is obviously what was showed was both benefits and disadvantages. Benefits in terms of prevention of eclampsia, prevention of large for gestational babies, and gestational diabetes. But in terms of neonatal outcomes, yes, they were a bit adverse compared to patients who were not obese or who have not undergone bariatric surgery. So I think a careful monitoring of the pregnancy, because all of you will keep encountering these patients, and bariatric surgery has become really common nowadays. We will keep encountering such patients. So these are the things to be kept in mind. Again, congratulations for a very, very well managed case. Thank you.
Any comments or suggestions or questions?
This one, this patient was very important. In fact, when I was a little worried that how do you manage? In fact, she not a doctor, she's a PhD. And when I pulled out one case report of them, the next day when she comes from you, she handed me another case report. She said, "Don't worry, they are not just fine. Now I'll be the third." So, and she's very keen that a case be reported. So that it could be a means for others to be added. And then, we driven towards medical definition.
They were very good family laws case.
Thank you so much.